Welcome back, everyone, to the Catalyst Pharmacy Podcast. Super excited today. We had Tim Mitchell on with Mitchell Drugstores in Neosho, Missouri. Some credentials he had, a few of them of the long list, are a multi-store owner. I think he owns 5 stores now, with a cool approach with some substandard community-based models with 100% MedSync, but also a cost-plus arm to his business as well that's been able to get some traction, and they're seeing some growth out of it. Talks about community healthcare workers and all that. He's a board member with the LineRx, a part of every program you can imagine, but also CPSN lead luminary in Missouri. So excited for you to listen to what he has to say. We'll take you there. One thing I like to start with, though, is I know you're a 4-timer on this show, Tim, and you've made the circuit before. So one, appreciate you coming back.
Always enjoy it.
And then, but I want to refresh everybody, who you are, where you are, a little bit. I know you're in Missouri there, Neosho, I believe is how you say it.
Kansas City. All right. Yeah. All right.
Give us a quick overview of kind of a little bit of the journey, and then your kind of your store footprint from there.
Tim Mitchell from Southwest Missouri, specifically Neosho, Missouri. We have, 5 stores. We have 2 traditional community pharmacies. We have a cost plus pharmacy, Mitchell's Cost Plus. We have a long-term care pharmacy, closed door. And then we have a sterile infusion and non-sterile compounding pharmacy in Neosho as well.
Okay.
That is part of a different corporation, but I'm co-owner in that as well. It's called Vital Care of the 4 states.
Right. Okay.
So don't have a lot of daily interaction with the infusion pharmacy because I'm busy running all the community sites and the long-term care. So the journey started, graduated UMKC in 96. And most of my employees were born after that. So it's ooh, it makes me
younger crowd there at Mitchell's Drugs.
That's probably why I'm a 4-timer, is because I'm old. I think our first episode was, I don't know, maybe 25 or something like that. So I don't know how many you're up to now, but I started working for a big chain pharmacy, started with a W, down in Northwest Arkansas, but I was in Southwest Missouri, worked for about a year. It was fine. It just, I just wanted more. I wanted to do more things and felt like I was kind of being held back. I knew about immunizations. I knew about, back then they called it pharmaceutical care.
Okay.
And diabetes management, a lot of different things. I want to be able to do these kind of things. Of course, working for a corporate, you pretty much have to do what they ask you to do. And so I decided I would start looking around in our hometown here in Neosho. I worked in Joplin at the time, and which is just north of here. It's where the big tornado went through about
devastating
years ago,
one.
killed a bunch of people. It's a bad deal. Actually, when that tornado went through, sorry, squirrel.
Me too, man. This is how this is going. That's okay.
We're going to be off in the whole left field here in a second, but that tornado, I think, wiped out 5 pharmacies. There were 3 chain pharmacies and 2 chain pharmacies, which were the same. They were Walgreens stores, and then 3 independent community pharmacies. And I helped Dave Sterrett get his medicine shop going. I mean, it was an effort from NCPA and MPA, but it was a bad deal. Anyhow, going back to my journey, I came back to Neosho, and there were a couple of independents in Neosho. Decided I would kind of just put my resume in and see. And one of them had just hired a new pharmacist, or an older pharmacist. And he said, man, if I hadn't hired him, I'd hired you in a minute. So I went to the other one, and I do believe God had a hand in this, because the first thing they said is, yes, we need help because this pharmacist is leaving in 3 weeks. And I was like, oh, shoot. So I met with the owner, his name was Philip Roselle. He's down, and he's one of your customers as well. In fact, he's the one that got me on the platform pretty much, because he's like, you got to do it. You got to do it.
Thank you, Philip.
He's in, it's now Medical Arts Pharmacy down in Fayetteville, Arkansas.
Oh, yeah. Okay.
Very, very progressive.
Yeah.
And
great pharmacy.
He had that store, well, he had a different store at that time, and then he had this store up here. And he told me, in about 6 years, I want to start slowing down and start thinking about retirement. And that was in 1997. And I said, well, let's do it. He said, I'd like to sell you the store in, 6 or so years. So I just want you to be aware of that. I said, okay, sounds good. Handshake deal, no contracts or anything. And, I worked for Phil. He taught me a lot. It was like a junior partnership, really, if you think about it. I don't know if you remember that term.
Yep.
And I will tell you, Phil, we became, Phil's always been involved with PBA Health, which was our co-op out of Kansas City.
Yep.
Very independently minded, and, helped start a distribution center. He served on the board. A lot of different things that were going on. He taught me how to do things, but I also showed him some things as well. That immunization thing I wanted to do. I told him, I said, I'm going to go get trained and we're going to do this. He goes, let's do it. So one thing about Phil is he didn't hold me back, and I love that. And in 2002, he called me and he's like, he's in Fayetteville, which is about an hour away south of here. And he's like, hey, 2003 comes. I want you to be ready because I'm going to be ready to sell the store. And it's going to be for the agreed price that we talked about 6 years ago. And I'm like, oh my gosh, and he's like, Tim, this is going to be a steal. You just need to do it, And I'm like, okay. So I can't tell you the price or you'd probably laugh me out, but
it's all right.
It was amazing. Phil is like a father figure to me. He's been my mentor since I started working for him. So, and he just celebrated 50 years in pharmacy.
Oh man.
In the meantime, after he sold my store, he bought 2 more stores, and he wanted to slow down, but he bought 2 more stores and merged his store into one of them. But they became one of the leading COVID vaccine providers during COVID.
Yeah.
I think he did like almost 200,000 vaccines. It's crazy. I mean, he was a distributor as well. He had a ultra cold freezer. But anyhow, so my journey of ownership really started in 2003. And just started trying to figure things out. We started doing long-term care when I worked for Phil, and continued to try to be innovative, adding immunization opportunities throughout. We started off-site clinics. I had people calling me going, what are you doing? I didn't know pharmacists could do this kind of stuff. Like I said, this is late 90s, early 2000s. And then I get a call, I don't know, probably about, maybe that was a little bit later. But APHA ended up recognizing us at their Seattle meeting as a small pharmacy immunization champion. And I got an award then. So it was really cool to be able to be recognized for something that people thought we were crazy. I had people call me saying, doctors and nurses are supposed to do that. Pharmacists are supposed to count pills and put pills in a bottle and do what they're told to do. And I said, but I'm going to live life on the edge and do these things the way I think they should be done. So anyhow, we started doing things out of the box, and I had that one store, and then about a year or two after I opened the store or purchased the store, I had a physician call me that had left a health system about a year prior, and he said, I'm moving back into the area because he had a non-compete. He said, I want you to open a pharmacy with my clinic. He said, can you find me a building? And I'm like, what the heck? I didn't know I was a real estate person. So you know how pharmacists are. We know everybody.
Yeah, you do. You do. And you do everything.
Yeah, so I told my real estate friends, and we found a building, and he was in another, he was on eastern Missouri, southeast Missouri, working over there. I called him and I said, hey, I found this couple buildings, and next time you're in town, come look at them. We'll see what we can do. Maybe we can buy this building. And he called me like a month later and said, I bought the building now, so be ready because we're going to move. You're going to open a pharmacy. I'm like, I don't even have a business plan put together. When are you doing this?
Okay, man.
So in March of 2004, we opened up, it was called Country Care Pharmacy at that time. And the crazy thing is the pharmacist that I worked for at Walmart who was the manager there, I called him and I'm like, hey, you want to come work in the pharmacy with me? And he's like, sure, let's do it. So he came down. That pharmacy started from ground zero. And when doctor was seeing patients, first day he had a full waiting room. And I'm like, goodness gracious, what is going on? Pharmacy never lost any money at all. It was like,
that's such a crazy like new startup story. Like that, not everybody gets that lucky. That's nice.
And I'm sorry you asked for the journey, and it's been 25 years, so it's a kind of a long journey.
It's good.
In 2005, I had the opportunity to open up a medical equipment store. We did full oxygen, CPAP, medical equipment of all kinds. We even started doing some other types of consulting type things. We have our diabetes support group that was meeting on a regular basis there, and it was a building that we just rented, and it was going well. And then, of course, DME kind of went to pot, or in the early 2012 something. Right. So we ended up merging that with our store. But long story short, in the late it was about 2010, we had an opportunity to open up a specialty pharmacy and compounding. Yeah. And so that's where Vital Care kind of spun out of.
Okay.
And so we did that. And then in 2012, USA Drug purchased the other independent that I had applied at that already had filled the role whenever I took this other position. USA Drug purchased it and kept it open for about a year or two. And then, if you remember the big Walgreens purchase of all USA Drug stores, about 150 stores, like $450 million deal or something. I don't remember how much it was. But then our downtown store then got word that Walgreens was closing that location, was going to merge it into their location out here on the boulevard by my other store. And so, and it's not that far away. It's a couple of miles away. So I already had two pharmacies in one town because one was in this clinic on the west side of town. One was on the boulevard, which is kind of our main thoroughfare,
right.
Where school is and everything. But there was nothing downtown now. And so our founding fathers of our city start calling and it's like, Tim, we need a pharmacy downtown. I'm like, I have one out here on the boulevard. I've got one on the west side of town
already, man.
They're like, we want one downtown. And I'm like, well, if I don't do it, somebody else probably will. So I started looking around and I called my real estate friends and I said, hey, I want to buy that building that Walgreens is moving that independent out of. And they said, well, you can't put a pharmacy in it because Walgreens has a thing in the, but there was a building right beside it that was just as big. It was in terrible shape, but so my business partner and me, we went and looked at it and figured out a price, and we're like, okay, we can buy it. We can just put all of our medical equipment. We can put all of our Vital Care infusion stuff in there. And, it'd be good because it was like 5,000 square foot. And so long story short, as soon as I signed the papers on everything, we were down there looking at it and it was bugs all over the floor and looking at the ceiling falling in. We're like, well, we're going to have a lot of work ahead of us. I get a call from another physician friend who's a good friend of mine, still is today. He's like, hey, I hear you just bought a building. And I'm like,
no, it doesn't sound like you could move much in that town without everyone knowing about it. But go ahead.
So he's like, can I come down and look at it? And I'm like, sure. Yeah, come on down. He said, I'm going to bring my wife. So they came down, looked at it, and he said, I'm leaving the hospital up the road. I'm going to open up my own practice. We want to buy your space here. And I'm like, I don't think it was for sale because I was going to put but in the long term, Craig and I are good friends. I said, Craig, you can have it for what I just paid for it. The problem is I don't want to pay, the extra taxes on it. So let's just lease it for a little while and then we'll sell it to you. So anyhow, we worked out an agreement. He redid the building. It's still there today. And we opened up a pharmacy in our downtown. So we had 3 pharmacies in this town that were community pharmacies. So we had a huge market share for this little town of 14,000 people.
Right.
That was in 2013, and that pharmacy's still going. It's Mitchell's Downtown Drugstore. Yep. Now, we ended up having to close our Country Care pharmacy. The physician passed away, and another clinic bought it, but they wanted to do something different with the space. And to be honest with you, margins were shrinking. Mm-hmm. We felt like it might be good to just go ahead and consolidate. I don't like closing stores because
Nobody
it
does.
costs you money.
Yep.
But it made sense because of, the volume was shrinking and the way they were doing things. And it was an FQHC, and they like to funnel a lot of their scripts to their own pharmacy in another town. So
yep.
Long story short, and then in 2015, we had the ability to expand into the building we're in today here just down the road from where we were at. We were in a grocery store. It's another 5,000 square foot building that has our long-term care, has our cost plus pharmacy, and our Mitchell's on the Boulevard store.
Okay.
It's got a beautiful fountain out front that we were able to put in, and
nice.
We added on. It's an old bank, so you can imagine it's got huge safes in it.
Yeah. What's with this? Like, I feel like there's a movement of pharmacists moving into old banks. I think.
Yeah, didn't Scott Pace and his wife do a bank?
Scott did that. Yeah. Somebody else was talking about it.
We had a natural drive-through. We actually moved the drive-through, but we used the same window, and so we've got about 5,500 square foot here. And we actually just recently opened up our own clinic, and it's called Mitchell's Health and Wellness Clinic. And I can send you information on that if you want to know more about it. It's through the CPSN movement.
Okay.
It started with Big Tree, and now we've kind of just merged into our own thing. But it's direct primary care. And that's where we are today. I can tell you, it's been challenging, and I've made mistakes. I've learned sometimes the hard way. I always try to minimize my losses, but sometimes I lose my shirt on some things. That being said, we just like other community pharmacies, I like to use the word nimble. And I used that at the Cardinal show. We were there. I was speaking on stage. Nimble is my word, because if we're not nimble, especially in today's market, we're gonna wither away and die. Mm-hmm. So I'll shut up, let you ask questions, because I'll just sit here and talk all day long.
You're good. I'll let you, Tim, to be really fair. Dude, thanks for that. I know you've been on the show before, but I think it's just really cool to hear. We get a lot of people who's first-time listeners too, so it's like we get a picture of like what you've gone through, how you got there, and we got some people that listen too that haven't don't own a pharmacy yet. They may be trying to think about doing it. So that junior partnership thing you touched on, I don't think it's talked about as much, but it's still something that's very out there for folks that NCPA can do a lot of education on. Unfortunately,
I don't want to put a damper on community pharmacy, but it's gotten a bad rap over the last few years. Yeah. And it's saying, my youngest son, I was trying to get him to go into pharmacy. Tanner is my middle son. Yep. He's actually a pharmacist. He's actually in there working right now while I'm doing this. But my youngest son, he goes, Dad, I don't know if I want to go through the stress here to it. We adopted him when he was 5, him and his sister from Ghana, Africa.
Yeah.
Talent. He wants to be a physician. And I'm like, you know what? If that's what you want to be, I'm all for it. I'm going to support you, and he's getting ready to graduate next year and go to med school. So,
well, that's cool. Maybe some remote patient monitoring when he gets out of med school.
There you go. Well, he could help us run our clinic here, by golly. So.
Yeah. So let's talk to it. So you said you are the lead luminary, I think now at
Missouri.
With CPS in Missouri.
I took it by default. Trip Logan was the lead luminary for Missouri. He could be the lead luminary of the world.
Oh yeah, easy.
That guy's amazing. And Annie Eisenbeis is our leader in Jefferson City, and she works out of the MPA office, Missouri Pharmacy Association. And we have a team of people on the luminaries that just make my job easy. And I missed the meeting yesterday because I was on the call with you.
Oh.
I forgot. Oh. But that being said, they are just a stack of amazing individuals that in the state of Missouri has done some really, really good things with CPSN. Very proud of our. Yeah.
What are you doing right now?
Well, so the big thing right now is our vaccine gap closures.
Okay.
And we're moving in. We had phase 1, phase 2, phase 3, and 4. And we started with just our normal medication synchronization calls and using our community health workers to verify if people have had their pneumonia vaccine, their COVID vaccines, their shingles vaccines, their Tdap. And we just focused, Nicolette Matthey, you guys have probably had her on before. She came through the NCPA initiative a few years back, and they did a video on us. And she helped us focus on just certain things, like we're going to focus this, next couple of months on Tdap vaccines, making sure, and helped us kind of get some organization on how we were going to market that. and working through our Pioneer system. Guess what? Every time someone gets a notification that their prescription's ready, they also know that we have COVID and flu vaccines available right now.
Nice.
So, but using our community health workers in this program to do the MedSync calls, they're able to go through and do that, as well as social determinants of health, and going through and checking all the different social determinants of health issues they may have. And if they have, if somebody notices, it could be anybody that's talking to someone, they see a social determinants of health issue. We actually have it on our screening form now.
Okay.
If somebody marks, yes, I have a transportation issue, or I have a problem with paying for my prescriptions, our community health workers are notified, and they start working on that for that patient right then. And it could be they're in normal workflow and just doing their normal thing, and there's like, okay, here's a patient, I'm going to help these. And it may not be that they can help them right then, but it may be that they're able to, get to them after they find some resources for them to be able to access. It could be just something as simple as, I can't pick my medications up. What do I do? Well, we can deliver that to you. So, just simple things that sometimes people just don't realize are available. So those vaccine gap closures, trying to bring these people in for vaccines. Lacey's out right now she went to our downtown square and started walking from business to business, making sure people are vaccinated. She went to our city hall. She already had a vaccine clinic scheduled and went and did them, went to our county courthouse, did a few there, and just walked around the square. And now she's at a couple of nursing homes this afternoon. So, it's, just trying to get out in the community and doing those things. And so our CPSN group is working on these vaccine gap closures to bring those in. And they're bringing in extra dollars. And I think, if I remember correctly, I sent you some numbers, and I don't have them in front of me, but we've already brought in like close to $150,000 extra income for all these vaccine gap closures that we've been able to do.
Yeah.
Clinical interventions on top of the great dispensing fees that I'm getting from the PBM. But I can tell you, it's been a true blessing to be able to have those fees so that we can keep our head above water and all the other things going on. And like I said earlier, community pharmacy is getting kind of a bad rap, especially from people that are going into pharmacy school, and they're like, I don't know if I want to do that, with the walkouts and things. I can tell you, there's definitely things to be concerned about, and I'm concerned about it. Cash flow is not great, but I can also tell you I've never been more excited about the future of community pharmacy than I am today, because of all the things that are going on in community pharmacy and all the opportunities that are continuing to open up. CPSN has brought a lot of that to us. And using the Pioneer software, I can tell you, has made it much easier. We're doing care plans on every one of these interventions. Of course, every vaccine has a care plan. Now CPSN Missouri is using a jot form to be able to capture that data. I don't know if jot form will work with Pioneer or not, but we're looking at ways to try to make things as easy as possible for our pharmacists and our community health workers. So,
yeah, and you have a broad base of folks from a technical capabilities perspective in CPSN too. So they don't all have probably the same, I'll just say, skill set or tools in front of them that you guys do. So you're doing social determinants of health. I'm gonna back up and peel back some of the stuff that you just said. Yeah. So you're doing SDOH. Literally almost for every patient coming in on MedSync, and basically so it sounds like if you're at Mitchell's Drug and you have a maintenance med at all, you're on sync whether you know it or not,
we pretty much, you're right. Lacey and Tanner have pretty much made it standard operating procedure.
Sure.
If you come in on a maintenance medication, first thing we're going to tell you is we're going to put you on, we don't call it a program. We're going to put you on something that will help you be able to get your medicines on a regular basis. We're going to proactively call you. We're not going to work reactively. We're going to work proactively because it helps us too. We don't tell them all the things. I mean, I can keep my inventory down dramatically, but as a business owner, I'm like, oh, this is great. And this happened during COVID. Flip the Pharmacy popped out, and we're like, okay, there's some opportunities here. And then the NCPA fellowship popped in, and we're like, okay, there's a lot of opportunities. And the very first fellow we had used community health workers and doing MedSync calls and social determinants of health. And we're like, okay, this is great. So, but yeah, everybody that walks in, whether they know it or not, they're going to get put on a MedSync. Now, if they're getting an amoxicillin or
it's different, right?
Z-Pak or something or whatever. But if they got any kind of maintenance medication, they are going to be on MedSync. We have, I don't know, many thousands of people on MedSync. And we have a lot of individuals. We use the Rapid Pack system with RxSafe for our adherence packaging. We've got quite a few people. It kind of varies depending upon, where we're at, but quite a few people on adherence packaging as well.
Nice.
So, and we've got a crew of anywhere from 3 to 5 people working on adherence pack. They do probably 50% of our medications in any day of in our adherence area. So it's quite a few prescriptions. So maybe more.
It sounds like the lever you're using too to like I know a lot of people probably hear, oh man, they're like, how do they have time to record social determinants of health? How do they have time to like have community health workers do all this stuff? Well, it sounds like to me, tell me if I'm wrong, well, MedSync helps you have the time and predictability to do all of those things. And I know that's not anything new for the world. Like we've been talking about it for 10 plus years now, but man, it's talking about at getting that type of data at scale. The only way to do that, it sounds like, is have a predictable model.
Right. Just doing the vaccination part of it, or, while we're doing this, we also screen for allergies. You put allergies in your system. Guess what?
Yeah.
That's another opportunity to go to a payer and say, we've got all these allergies, or maybe it's, I don't know, whatever they're looking for. But going back to the vaccine gap closures, we're actually going to go to phase 2, 3, and 4. We're looking at diabetes, hypertension, asthma, and being able to start bringing out other disease states and being able to, and these are things that we can grow. We start small. They started with some pilot stores. They were doing chronic kidney disease on a few pilot stores as well. That trip was part of that as well. But I mean, there's a lot of things that are coming down the pike for CPSN Missouri stores. If you're not in health equity at CPSN Missouri, you need to get in it. It's huge. I'm going to put plugs in.
No.
People are like, what's CPSN done for me? And I can tell you right now, as a luminary, I tell people every day, it's kind of like the John F. Kennedy thing. It's not what CPSN can do for you. It's what you can do for CPSN. Because when you help CPSN, you're going to help yourself, because you're bringing all these opportunities, these payment opportunities to the forefront, and it's going to come back to you tenfold.
I love what we're doing there. The other thing I don't want to leave that conversation without talking about this, because I think Tripp was one of the very first people I even heard the term community health worker or community healthcare worker in a pharmacy. And I remember the first time I heard him talk about it, I think I sounded so dumb. I was like, what? Like who? Like and
did the same thing. He was my teacher.
Yeah. No, he was really patient with me. So, but
I've never seen Tripp unpatient.
So he got me there, and I get it now. But between, like, as far as people putting it in practice, like Tripp or you and Bob Lomanek seem to be like some of the first like early adopters of that. And to me, it's such a differentiator. And I know people who listen, if you listen regularly, you've heard me already say this, but with conversations with providers or payers or whatever you're doing, it's such a differentiator for a pharmacy where it's like, I also on staff have community health care workers that screen for XYZ.
Yeah.
Now you just totally differentiate yourself of why they should pay you to do things.
And Tripp talks about that all the time. And we're training our pharmacy technicians to be community health workers. And if you go out to a payer and say, our pharmacy technicians are screening for all these social determinants of health and whether or not your members have the proper immunizations and whether or not they're being adherent to their medications, and they'll be like, well, that's what they're supposed to do.
Yeah.
But then when you say, well, we have community health workers on staff, then we've trained them. It's not like they just have a new name. They've gone through the training. They've gone through the course. I actually went through it. Lacey's gone through it. she actually is teaching in the course now. But when you say you have community health workers, they're like, whoa, you have community health workers? Wow. Okay, well, maybe we can get something going here. This sounds good. And this is his baby, and it's grown and grown and grown. And, I still go to conventions, and people are like, you do community health workers, right? Or if I'm speaking at the convention and I talk about it, tell me, how do you bill for community health worker work? And I said, well, you have opportunities, but the way I looked at it, I didn't get paid right off the bat. I mean, we are now based on what we're doing. But I can tell you, what better PR person than someone that's working in your pharmacy? You go hire somebody that doesn't know anything about pharmacy, or someone that works in your pharmacy and is making outbound phone calls on a regular basis. And maybe even we'll talk to, social clubs or whatever about what they're doing. I will tell you, it not only gives them the people, the employees, another job to do, but it also gives them more job satisfaction because they know,
I imagine,
Mr. Jones, you just made sure he got a pneumonia shot, and he could get pneumonia this winter, and he could go to the hospital and die. And you just probably saved his life because he got a pneumonia shot, and now he's going to be better, hopefully healthier. We've got a patient that's 106 years old, and we used him as an example to our community health workers. And they're like, we love him. We don't want anything to happen to him. So,
right.
But, that being said, we are incorporating it in our normal workflow. And Pioneer has helped us. Tanner and Lacey have incorporated so many things right on the Pioneer. We print out our templates. We print out or we'll do our templates. We'll print out our immunization sheets. It's already built in. It's got everything there. It's got their information on there. All they got to do is check it off, answer their questions, and sign it. It's made it so much more efficient. And by putting everybody on MedSync, we have a little extra time. It almost seems like, what's going on? Why is it so quiet?
A little quiet, right? A little quiet.
So we can start working on these other things and get paid for these things. So it's not like we're just standing around. And we can manage our care. We can manage our inventory better. As a store owner, I would a lot rather keep $100,000 worth of stuff on my shelf than $250,000 worth of shelf.
Oh, amen.
It helps cash flow. And cash flow is tight no matter how much you have on the shelf.
Yeah.
Because PBMs aren't valuing what we're doing.
Yeah.
So lots of things going on. And, I think, I would be remiss if I didn't give my pharmacist credit. We just hired another pharmacy graduate from UMKC, Samantha Vance. I've got Tanner Mitchell, my middle son, who just graduated like 2-3 years ago, and Lacey Epperson, who is our lead clinical gal. She's amazing. I can throw things at her, and she just takes them on and runs and runs and runs. And she's like, hey, this one isn't working. We drop it. We go to something else, So lots of opportunities here.
Well, some of those stories, like a couple things there, and you tell me if I'm thinking about this wrong, because I've even had some people, like, just because I get to talk to a lot of smart people, I'm really fortunate in that way, ask me about the community health worker piece, and they're like, well, how people are getting paid for it? Well, I don't think that's the way to look at it. And it's not super expensive to put a pharmacy technician through this type of training. And I think you're right. There's total like job benefits. If the technician is into, hey, I would call myself the community healthcare worker, that piece of it. But it's also just like, I look at it too as sure, it could lead to billable events. Yes. But too, like, you could differentiate you when you're going to talking to physicians. If you're out in your community, if you're talking to any of your public health folks that either are doing preventative measures in some way, whether it be vaccinations or anything else. So like, it's a whole different way to me of like just changing the framing of what a pharmacy can do.
Right. Right. No, I agree. I will say, when we started talking, this was, prior to COVID, right before COVID hit and during COVID. It's terrible that we measure everything according to COVID, but yeah, we went to a rural health, rural health clinic that was owned by a hospital. They had like 14 clinics. And they almost acted like they were a little bit shocked that we had community health workers because we have community health workers.
They're like, no, that's what we do. Like, that's our thing.
And I will say they were a little bit taken back. They're like, well, but you probably can't do what we're doing. And I'm like, we're the ones managing the pharmacy side, which your people are calling our pharmacies. Guess what? We can be proactive. You don't have to be reactive.
Yeah.
We can work on it right now before the patient even gets their medicine. We're going to make sure they're adherent, and then we'll send you that information. And they're like, oh, I didn't know you could do that. So, I know hospitals and clinics have employed community health workers for years, long before we did. And we're kind of probably in the infancy or childhood stage of community health workers in the pharmacy. But I'm telling you, it's quickly getting more and more traction. Payers are noticing it. I think when payers notice it, then hospitals and clinics are going to notice it because they're like, hey, this is going to be something we can cash in on. It's going to help the pharmacy. It's going to help us. Some, you can beat it in their heads and they still don't. I mean, there's some people that think they know more than pharmacists do. I guess they'll have to figure it out on their own. But I will tell you, it's been an interesting journey learning how to navigate that. And Tripp has been a true champion when it comes to that. Lacey and Tanner Lacey's probably the number one champion as far as, because she's teaching the course every Tuesday night. She leaves a little bit early and has an online course that she does. And I think it's through the health equity, through CP, or through, oh my goodness, I can't remember the name of it now, but it's amazing. In Missouri, we have a grant, so it covers the cost of training them.
Yeah.
But normally it's about $1,500 and you can train a community health worker. It's like a 6-month course. And I think you'll get your return on investment tenfold. Easy.
Right. All day. I want to take a quick second to highlight, I don't know if we call it grit or dedication or whatever, but like you were just talking about Lacey teaching at night. You're talking about she's literally walking through the entire, I don't know if you called it downtown courtyard area, whatever it was, and all of that. And then everything that Tanner's doing as well. Like you've been able to curate, it sounds like, a super dedicated staff. So I just wanted to say it out loud.
Yeah. Tanner is actually going to go to nursing homes next week. Today was Lacey's day. They're both, and I think they enjoy it. And I can tell you, Mark, this is what I was doing. Remember when I was telling you whenever I started business, I would go out at 6:00 in the morning and do shots at businesses and work till 7:30, 8:00, come in, open up my store, give shots all day long, close my store, go give shots after work for a couple hours, at, a church or whatever, and then go home. And my wife's like, and she was helping me. I mean, she wasn't giving the shots, but she was doing the paperwork. She would go in the mornings, and it was and that's when Tanner and Taylor, who's working at my store as well. She's not a pharmacist, but Taylor's running the business side of things and really helping me. She's actually out doing drug tests today. So, but I can tell you, yes, I've been blessed, and I totally think they are fully bought in. The grit is there. They enjoy being involved in the business and being able to get creative, being able at the clinic and doing some other things as well. So a lot of interesting things going on for sure.
So let's segue into your Cost Plus Pharmacy.
Okay.
That's super interesting. That I didn't want to leave the episode without talking about that. When did you open that? Give me some of like the inspiration for that. Obviously, as much as you can get dollars out where you can set your own price and not be a price taker and be a price setter. Absolutely, most of the businesses that operate in the world actually do that. So, I just wanted to get a little bit of like, hey, what's your thought process there? How are you feeling about that business as well?
So I started thinking about the Cost Plus Pharmacy when I started hearing reports. I think there was a Scriptco that opened up down in Texas a while back and was on Good Morning America or Today Show or something. And then there was another one that had a traditional pharmacy. I can't remember the name now. that had a cost plus pharmacy, and I read a story, and I'm like, I'm going to do that. Well, then, of course, COVID hit. And then I heard Blueberry opened up during COVID. And I'm like, okay, well, I'm going to watch Kyle and see what he does.
Yep.
And I had a few conversations with Kyle. Kyle, he's a great guy. But I was like, man, I don't know if I can do this on my own. I don't know if I should do it during COVID. This is crazy. So we came out of COVID, and of course, Tanner was in pharmacy school during COVID, and he got out. Lacey, by the way, Lacey's class was the first class when COVID hit, and she graduated via like this right here.
Zoom or whatever, right?
Yeah. Tanner had a real graduation, but it was after about a month of working, Tanner and I were working here at the Boulevard store, and I looked at him, and he's like, these PBMs are killing us. And I said, man, I know it. I said, I don't know what we're going to do. I said, I'm thinking outside the box here. And I said, how would you like to have a pharmacy that wouldn't have to deal with PBMs? He goes, Dad, let's do it. And I said, what we're going to do is we're going to do a little research. Let's talk to Kyle. Let's talk to some other people. Let's do some research because, I don't want to jeopardize my PSAO contracts. We're with Align RX, and I had a conversation with them. I actually sat on the board with Align and get some insight. I don't want to get in trouble. And so she's like, Melanie and I were talking kind of offline, and she's like, I'd probably set up a different corporation. So we just set up a different corporation, but it rents space from this building here, or from this business here. And we got a Pioneer system. We linked it all up. It's on Central. And we thought, well, we're going to just, figure it out. I can tell you, to this day, we've been open a year and a half. We've not lost money on one single prescription. Our average dispensing fee is about $10 per prescription. Of course, it's low-cost generics.
Sure.
We've got about probably $3,000 or $4,000 worth of inventory in the pharmacy. We have it's actually on the other side of the wall here of this office. We just took an office and just made it a pharmacy. It's got its own sink. It's its own, the stuff that the pharmacist, one has its own refrigerator and everything. The inventory is really low. Everybody there is on medication synchronization. We do fill antibiotics and things. But over the last year, we've been able to partner with a friend of mine that has a direct primary care business here in town. He's got about 1,000 members on his direct primary care. And I just told him, I said, I'm going to grandfather all your people in for a year for a free membership. And so that started the people walking in. And so we were able to do that, and they were taking advantage of that. The normal, there's a membership model and non-membership model.
Right.
The normal membership model is like $99 a year, I think. Or if you want to do it 6 months, it's like $59. And you can look at our website. It's mitchellscostplus.com, I think, or mitchellscostpluspharmacy.com. People that are members get a better cost of goods. And so it's still about that $10 dispensing fee. But we highly encourage people to do 3 months or 6 months worth of medication at a time. It helps us, and we can be proactive at filling it. If you need metformin, we'll give you 6 months of metformin as long as your doctor's okay with it. Right. If you don't write it that way, we'll call them. We do it. They get one dispensing fee. And, we had the very first month that we were open, we've had multiple people call. I've been getting my prescriptions through mail order, and it costs me, $350 every 90 days. And we figured out what the medicines were, got the prescriptions. It was $350 for 6 months supply. So we cut their prices in half, cut their numbers of trips down to the pharmacy, and made them super happy. So, and they're members today, actually. So, Taylor, and we keep our costs low because it's in this building, so we can share our employees. So Tanner and I, or Lacey or Sam can come over and fill if we need to. We always staff 2 pharmacists here. This pharmacy's at the Boulevard's pretty busy. Because we're also overseeing the adherence area, which we just formed a separate adherence area. It's also got the long-term care pharmacy here, and it's got the cost plus pharmacy. So there's lots of duties for pharmacists to oversee. That being said, anytime somebody walks in or there's a phone call, if nobody's there, we shut the door and it'll automatically send a message to the Boulevard store through our phone system, and then we can take care of them and get them taken care of. We can dial on to the Cost Plus from over at our Boulevard store as well and check things. So Tanner always keeps that up, and but we set up a direct account through PBA Health and another wholesaler for just general cost, just dirt net cost, no rebates involved.
Don't give me a rebate. Yeah, just give me a flat.
We're just
number.
looking at the dead net cost.
Sure.
Drugs. PBA actually has kind of. I don't know if you've heard the new like Farxiga and Jardiance. It's called Brinzavi. They actually just came out with that, and Mark Cuban actually had that not too long ago. And I told PBA, I was like, you guys got to carry that. Well, they're carrying it now. This drug we're able to sell in our Cost Plus for $59 for a month. Jardiance is what, $500?
Yeah, Jardiance is like $400, $500.
Yeah. And Farxiga same way. So those are the kind of things we're being creative on and being able to try to come up with some, new and innovative ways. Tanner's like, if we can just get this bottle of Eliquis down to $59 a month, and I'm like, good luck.
Yeah.
The Inflation Reduction Act, that's not going to happen.
Tanner, keep fighting the good fight, man.
Yeah. He's like, we're getting robbed on both ends. I said, that's probably true.
That's fair. So. Does that help you? I imagine it does. That made me think through also. If you're an employer with maybe even a self-funded plan or not, imagine in a town of 15,000, you probably do have some self-funded employers there. You probably helps give you another way to have a conversation if it's obviously layering in the preventive side of the world with immunizations and things like that. But also, hey, look, like probably my cost is better than you and it's published, man. That's
right. So I can tell you that the very first month, Lacey and I went to a small town just east of here, actually a town I grew up in. They called me and they said, hey, our insurance premium just went up 50%. We can't afford it. We don't know what to do. We're going to have to go to a different plan and we got to figure something out, So I went over and talked to them. And I brought my direct primary care friend along, and we both got contracts. Whenever we went, I didn't know they were having a city council meeting. I just thought it was a meeting with a couple people. We walk in, and there's people everywhere. The city council sitting in their chambers. I'm like, oh my gosh, this is an official meeting.
This is like real
people, and they're like, luckily I had things lined out, and so they paid for memberships for our Cost Plus pharmacy for all of their employees. And for his direct primary care practice.
Wow.
Now, granted, it's not a big city, but it's a start. And so, self-funded employers are realizing the cost savings tremendously. You still got to have a major medical, for something major. Mm-hmm. And if you've got somebody that's on, really high dollar specialty medications, you're going to have. They ended up just doing an HSA for these people that have really expensive medicines, and they said use that to help pay for it.
Yeah, plus layer on some stop loss or something. Yeah. Plus they're probably layering on some stop loss and things like that too.
Yeah. So it has, and then on top of the Cost Plus is when we've been able to layer some services, and Lacey and Tanner are doing that now. We're doing our point of care tests. We are adding lab testing in there. With our clinic that we have, we're doing, just a lot of different things that are outside the box of counting pills and being commoditized on everything that we do by PBMs. So, and we're utilizing that knowledge that we get from CPSN, from that Pioneer Facebook page that Ben Jolly started. We learned so much from that. It was amazing. I think Ben's charging for his consulting now finally, but
finally he should be.
But there's so much. I always tell people, learn from your peers. I mean, don't try to think you can do it all by yourself. I think it's so important. If you see something that somebody's doing, call them up, say, hey, is there a way we can, and I don't have a problem paying somebody a little bit of dollars to kind of help me do something to help me get started. Trip, hired him many times. Now he's in such demand, you can't work him in. I can text him, and sometimes he'll respond back, but he always is accessible.
Yeah.
Same way with Jeff Harrell. I think you had him on not too long ago.
Yeah.
Jeff is an amazing mind. And Mike Burns, a friend of mine, that's got Auburn or Auburn pharmacies. Those guys are what keep me moving forward, because I see all the different possibilities that are going on. So
that's good. It's good to hear what you're optimistic about too. Like that's good. It's easy to like totally. And I get it. I'm not trying to gloss over any of the state of the world with reimbursement and legislation, and let's hope they can get that legislation done pretty soon too. So I
told you I talked with my congressman, and he thinks PBMs are good, and I hope he sees this podcast, because I can tell you I invited him to my store. He hasn't come yet, but I may have him coming in October, and I'm going to show him what's going on. He keeps saying, well, PBMs lower drug prices for patients. And I'm like, you don't see what's going on behind the scenes, buddy. And I think, like my state senator, has been messaging me, and she understands what's going on. But this is a Medicare thing, and it's a bigger thing than just a state. It starts at the states, but it goes to the Medicare. And NCPA's push for fight for the finish or whatever, we got to continue to get something going. A lot of people are saying, no, that should be, the FTC. Yeah, them too. And they're on.
Yeah, them
they're
too.
on. FTC's all over it.
Yeah.
We need to make some bills to stop these guys, and because there's just too much money in it for them to just drop it and run. They're not going to do it.
Yeah, and it's a government-funded program. I mean, you have to, in my opinion, have protections to prevent the dismantling of access to care. It's literally what's happening, right?
Well, my congressman thinks it's all the drug makers, and I will say, drug companies are in it too, but they're just paying the PBMs back. It's like, you pay me, and I'll put you on formulary, and nobody, most people don't understand that, and I think our congressman understands that. But I will tell you, it bothers me that they won't look at the whole picture, because there's more to it than just the drug makers. There's more to it. I mean, follow the money.
It's not list price. It's list to net, right? Like, all that stuff. It's interesting. I'm really like encouraged though that you and everyone else don't get too discouraged. Get active, I guess is the way I would say it. Yeah. Where you're like, you know what? I'm not going to just get mad at this person. I'm going to invite them here and just walk them through everything I'm showing, all the data we have, all the data everyone else has, and go, look, I'm not saying they're all bad, but it's not good. Right. PBMs were invented to help, process claims, and somewhere in between now and then they got super greedy, and unfortunately they take it from both ends now, and now they're taking it pretty much all. So we know who the fat cats are, and so go to NCPA's website and sorry. No, dude, absolutely. If you weren't going to plug it,
we got it. Yep. And I just got elected to the NCPA PAC. Steve Giroux pulled me in, who's a big Bills fan, but I'm showing him this if he's watching this. I send him videos every day.
We have to blur that one out for him.
Sideways. But I will say Josh Allen's a pretty amazing quarterback. He just doesn't have the team that the Chiefs have. So hopefully the Chiefs will be able to pull it out again this year. Get a three-peat.
Get a three-peat. I know. Gosh, they've been studs. It just started this season. Just kicked off. Well, man, I appreciate you spending so much time with us. Really.
I want to put in a plug for the Pharmacy Frontiers.
I was going to plug it. I was just about to plug it. So Tim and is it John Good? Is it
Daniel Good?
Sorry,
he's from Mercy in Springfield, Missouri. Yeah, he's a pharmacist.
Yep. Mm-hmm. So Daniel Good and Tim Mitchell do a podcast called Pharmacy Frontiers now. We're going to put it in the show notes and the links to all that. So if any of our listeners here want to go check that one out, right? Right. Like and subscribe. So go check that out. It's a great podcast.
Well, we're trying to. It started off a little rough, and it's still a little bit rough. We're not as professional as you guys, but we're having fun. We're trying to talk about different topics. So we were focusing mainly on Missouri, but we're looking at other things, and you can learn some stuff. We just recently had on the UMKC business plan for the NCPA business plan competition. Yeah. They were top 10 in the nation.
Oh, that's cool.
Yeah, we were proud to have them on. So anyhow,
also, I don't know. I look at this and I go, if you're worried about something being state specific, go listen to it anyway. And the reason why I say that is we had Bruno on with he's a CPSN luminary in California, and just dropping all sorts of like cool stuff they're doing with either payers or Medicaid or whatever, and it just gives you ideas to go talk about your own. If you've got connections into your own state or plans that you work with a lot, it was really a great way to get inspiration is listening to what other states are doing and what's working for them.
You're right. Right. Lacey that works for me. I'm the lead luminary, but Lacey is the facilitator for CPSN. Mm-hmm. We've got, I think, 6 or 7 regional facilitators. And they're the ones that are getting the job done. It's amazing. I mean, she's definitely a go-doer. And she's even telling people, if you need me to come work on your Pioneer system to help you with, care plans or whatever, I'll dial in and help you, or I'll come to your store and help you because I let her spend a day on CPSN stuff every week.
That's cool.
To be able to do those kind of things. And it's been amazing for our stores. It comes back to us tenfold. I mean, it's an investment. But I can tell you the stuff that she's coming up with and she's sharing with other CPSN stores is really amazing. So we appreciate the opportunity with CPSN for sure.
Well, I don't want to let you get out of here without a prescribable. So what are you watching, reading, listening to, doing you think other people listening might be into?
Well, it's not related to pharmacy, but, recently Tanner and Taylor both got married this summer. And my oldest son was been married for like almost 10 years now. But Tanner and Taylor were married within 3 weeks of each other, by the way. And I'll remind them of that again, 3 weeks of each other. It killed mom and dad. Our youngest 2 are twins, and they're at Missouri State in Springfield. And I will say that my wife and I have become empty nesters. We have the puppies. And so we've decided to tack on a little bit of traveling, not a lot because I've been busy with the pharmacy, but we've done a little bit, and we started going to some concerts. We are doing some 80s, 90s concerts and just trying to spend more time together and kind of reconnect because it's a whole different life when you're an empty nester.
Yeah.
You'll be there someday.
I got one in college now and the other one in high school, so I'm probably not super far away.
And then we just recently started watching something on, I think it's Netflix. It's Suits. You guys
Suits.
Heard that?
Yeah.
I'd never watched it. Of course, it goes back, and I think we're just in like season 2, but just trying to spend some time together and take the dogs for walks and trying to breathe a little bit and relax. I'm not a big book reader because I'm too ADHD to do that. But I do listen to podcasts, and I listen to your podcast regularly, and try to make myself a healthier person. I've got a lot of work to do on that for sure mentally.
Oh gosh, yeah. I'm on a health kick right now. I don't know. I've got my annual butt chewing from my doctor recently.
Yeah.
That's my kick right now is eat a salad. That's my prescribable. Basically, was what I got told.
Yeah, we put you on a GLP-1.
I need to get on the juice. We just
recently started doing the compounds here. That's really taken off. That's another thing that Lacey's been doing. So
it's doing a lot of good for people too. Like I'm sure there's risk and issues, whatever. People can have the feelings about all that stuff, but it's doing good stuff for people.
I agree. I totally agree.
So all right, Tim. Well, again, thanks so much for being on.
Thank you
really
for having me.
Appreciate what you're doing in the industry for everything and for everybody else as well.
Not a problem. I'm glad to be a 4-timer. Thank you for having me on again. Hopefully I don't wear out my welcome too much. So.
No, we'll get you on for a 5th. All right.
All right, man.
All right, see you.